Hi everybody, this is DNH 146 Perio, and we're going to be discussing chapter 21, which is the periodontal debridement chapter. As you know, periodontal disease can be site specific, so treatment is going to be determined on a site-to-site basis for each particular person, and it differs between individuals. So treatment again is determined on a patient-to-patient basis and a site-to-site basis. Tissue response is considered a critical factor in determining whether or not periodontal therapy has been successful. So we as dental hygienists are in charge of what we do on a daily basis is non-surgical periodontal therapy. The initial phase is to control the supragingival microbial biofilm, as well as the disruption of subgingival gram-negative microbiota, and this is to delay the repopulation of the pathogenic microorganisms. So the origin, as you know, of the subgingival biofilm is the apical extension of the growing supragingival biofilm. So we need to really concentrate on oral hygiene self-care with our patients, and incomplete subgingival instrumentation as well. And that's why we need to really emphasize the patients needing a professional to help treat them for their periodontal disease. Non-surgical therapy is returning the gingival tissue to a healthy, non-inflamed state that can be maintained easily by the patient as well as the practitioner. I'm going to repeat that again. So non-surgical therapy is returning the gingival tissue to a healthy, non-inflamed state that can be maintained easily by the patient as well as the practitioner. So let's go into a little bit of terminology. We have scaling, and that's the removal of dental plaque, calculus, and stains from the crown as well as the root surfaces. And that's performed both supragingivally as well as subgingivally. Then we have root planing, and that's a treatment procedure designed to remove cementum or surface dentin that is rough and impregnated with calculus or contaminated with toxins as well as microorganisms. Extensive root planing is not needed to obtain healthy tissue, unlike when I was in school. So now we call it root debridement or root debridement, depending on which school you go to, and that's the removal of foreign material like plaque, biofilm, and calculus, or dead tissue from the crown, the root surface, and the pocket space, the pocket wall, as well as the bone surface, while conserving the cementum and achieving a good tissue healing response through control of bacterial infection. So it's quite different from root planing, where it was the intentional removal of all the cementum to get that glass-like surface. So periodontal debridement includes the root surfaces, the pocket space, the pocket wall, as well as the underlying tissues, versus root planing was only concentrating on the root surface itself. So scaling and root planing is no longer the gold standard. We have supragingival debridement or supragingival scaling, and that's the removal of plaque and calculus coronal to the gingival margin, as well as subgingival debridement or subgingival, the deep scaling that the patients refer to, and that's the removal of plaque and calculus apical to the gingival margin. Then there's something called deplaquing, and that's the removal of the subgingival dental plaque after the completion of periodontal debridement. This is performed at the reevaluation or supportive periodontal therapy appointments. So we are always deplaquing. Again, we are trying to convert that gram-negative anaerobic bacteria, get that out of there, and encourage the repopulation of a healthier microbiome subgingivally. So it's recommended at the reevaluation appointment as well as all the maintenance appointments. A prophylaxis is prevention, and that's to prevent disease. So when we start getting into what we are calling, what procedures we are doing, we need to be very specific in how we are going to code our procedures that we're performing for our patients in private practice. Antibiotic prophylaxis is when an antibiotic coverage is necessary before invasion of dental procedures that cause bleeding to prevent a bacteremia that ultimately could cause infective endocarditis or serious infections. Then we've got oral prophylaxis, and that's a removal of plaque, calculus, and stains from the exposed as well as unexposed surface. Polishing is performed to remove stains from the teeth and has not been shown really to have any therapeutic benefits, polishing per se, so we do recommend selective polishing for extrinsic stain because you are removing enamel and root surface anytime you take a polishing agent to a tooth surface and you're scratching that tooth surface, removing that fluoride outer layer. But now with Novamin, which is a new pro product, and the ACP technology that has amorphous calcium phosphate, we're really encouraging remineralization of the enamel and root surface. So we have added something called therapeutic polishing because we're treating the teeth. We're putting something extra on the teeth. So that was regular polishing. Then there's curettage, which involves the removal of the diseased lining of the soft tissue pocket wall. It can also be called soft tissue debridement, including the junctional epithelium and the underlying inflamed connective tissue. So the goal of curettage is to reduce or eliminate periodontal inflammation, get all that nasty stuff out of there and allow for healing. It's performed within the inflamed gingival tissues in shallow suprabony pockets. It's only allowed in some states. It's not what we are after anymore. We do what's called coincidental curettage. So anytime you're taking an instrument subgingivally and you're instrumenting the root surface and bringing that instrument back out, there's always going to be a little bit of epithelial tissue associated with it, but it's not an accepted procedure in periodontics anymore, according to the AAP. We used to do this, and that is where you would take your curette, and instead of it being closed towards the tooth surface, we were using the opposite end where the blade was against the soft tissue, and then we take our thumb and place lateral pressure and literally scrape off that necrotic or fibrotic gingiva or granular tissue. So the treatment of the inflammatory periodontal disease has really evolved from traditional scaling and root planing to achieving that smooth root surface to focusing on the soft tissue response. So inflammatory periodontal disease is a group of inflammatory diseases of the periodontium, including gingivitis as well as periodontitis. And the soft tissue healing is a natural process by which the body repairs itself after periodontal debridement or surgery. And the bacteria adheres to any surface that's rough or smooth, so we're never going to prevent bacterial recolonization, no matter what we do. So the mechanical non-surgical therapy consisting of oral hygiene, self-care, and periodontal instrumentation is really intended to prevent, arrest, control, or eliminate periodontal diseases to ultimately maintain the teeth in a functional state of health. Currently, periodontal debridement still remains the foundation for non-surgical periodontal therapy. So combined with the oral hygiene self-care and professional debridement benefits, we hope to get a reduction in clinical inflammation, to establish a more beneficial microbiome subgingivally, to have less pathogenic microorganisms and reduce the probing depths, as well as gain attachment. So the reduction of the probing depth is going to be from the formation of a long junctional epithelium, as well as reducing or shrinking the edematous tissue. So the rationale and indications for periodontal debridement are signs of gingival inflammation, elevated levels of bacterial pathogens, as well as the progressive attachment or alveolar bone loss or attachment loss. The purpose of periodontal debridement is to treat and resolve inflammation in the periodontal soft tissues by removing the irritants, which are both supragingival and subgingival. They're the biofilm as well as calculus. And the ultimate end goal is preservation of form and function of the dentition. So we want to measure and document, and we're going to go over that. Okay, we're going to be doing a full assessment, probing depths. We're going to be comparing gain or loss of clinical attachment, alveolar bone height with radiographs, bleeding on probing. We're getting a percentage of that and having a bleeding index, the visual signs of inflammation, the color, contour, consistency, as well as changes in the subgingival microbiota. So the outcomes of periodontal debridement, again, we're looking at all of these things that are going to be increasing, decreasing, and trying to come up with why. So the probing depths, root planing teeth with initially shallow probing depths of less than 3 millimeters slightly decreased or did not alter probing depths, but loss of clinical attachment did occur. Now that loss of clinical attachment is temporary. However, it does occur when we are heavy-handed and instrumenting and actually scaling heavily on 3 millimeters or less. So we need to take care when we're doing subgingival debridement that we're not hurting the clinical attachment portion of the attachment apparatus, and we're only doing a working stroke where it's needed. So subgingival microbiota, after subgingival debridement, we are trying to get the number of gram-negative microorganisms to decrease, especially those spirochetes. We're looking to increase the number of the gram-positive rods and cocci. And that AA, okay, the agrobacter, may still be present because those are the ones that invade the soft tissue. So that is one of the reasons why we used to extensively do curettage. But now we're knowing that it might be an antibiotic that's needed for these particular type of cases. So bleeding on probing, okay, that is after periodontal debridement, okay, we want to reduce the levels of inflammation. The tissue consistency with the reduction of inflammation, there's going to be an increase in collagen fibers. This allows reattachment of the junctional epithelium or that long junctional epithelium and increased resistance to the passage of the periodontal probe. And that results in a gain in clinical attachment. So the gain in clinical attachment is a decrease in the probing depths after periodontal therapy due to an increase in the resistance of the periodontal probe into the tissue and possible gingival recession. That's the reduction of the edematous tissue. So you've got your long junctional epithelium being created and some shrinkage due to, or recession due to less inflammation. And the inflamed tissue is then replaced by firmer collagen fibers. So the treatment sequence is something that we are going to be working with you with every patient after you do your periodontal assessment. You'll be writing up a treatment plan and discussing it with your faculty, and we'll be helping you if you've got any questions. So we need a dental hygiene diagnosis and a treatment plan. Now the dental hygiene diagnosis is really the AAP classification, but then we are adding as a hygiene profession as evidenced by clinical attachment loss, bone loss, evident on radiographs, those type of things. We're just adding the as evidenced by. We're concentrating on oral hygiene self-care instructions and specifically designing it for that particular patient. Do they need topical anesthetic or local anesthetic for subgingival debridement? You want to check for allergies. And after the treatment of care, you need to be bringing the patient back for adequate maintenance appointments to monitor. So we have different types of treatment sequences and anesthetics that we can use. We recently went over this in DNH 142 as well, but different types of topical anesthetic. You can have lidocaine, which is an amide base, okay, and for our topical, it's usually 5% lidocaine. Benzocaine, which is an ester type, that is topical only, available in the United States, and that's 20% benzocaine. Then there's Orachix, which again is a topical that's squirted into the pocket areas, and that's a combination of 2.5% lidocaine and 2.5% prilocaine. Then the Ceticaine topical, which is three ingredients: benzocaine 14%, butadiene 2%, and tetracaine HCl 2%. So when you're writing up your notes, you're not just writing down topical, you're writing down what you're using and what percentage. And the best results are obtained when a small amount is applied on a cotton tip applicator or the tip of your curette. And the tissues, of course, are dried prior to application to allow that agent to come in contact with the tissues, and then it needs to be held in contact with the mucous membranes for about 1 to 2 minutes. Now, a lot of these are acid-based. The pH is very low, so we don't want to keep this in the mouth longer than needed because it can really burn the tissue. There are alternatives, which includes the anesthetic patch. Now, I haven't seen these in 20 years. They were great because they were a lidocaine patch. You dry the area off, you'd place that patch on, you'd let it sit for a couple minutes, and you'd be able to work on that area. Now, it was great for the maxillary arch, but I never had success with using it on the mandibular arch just because of the saliva control. There's anesthetic rinses like diclone. There's the spray here. We've got electronic anesthesia, which is a very slow introduction of the anesthesia into the tissue. And the spray here is the Cetacaine spray, which has the 3 ingredients in it. I've only used this in radiology in the past number of years, but we do have that in case. Local anesthesia is best applied when you're doing it by quadrant or by sextant. We can also just do 1 or 2 teeth. So depending on, you only start what you can complete. So if you only have a half an hour left of clinical working time and you're just starting to get your scaling to that procedure, we might recommend to infiltrate 2 teeth and just work on the molars or whatever instead of doing a quadrant or a sextant at the time. And when you're treating more than 1 quadrant, you want to stick with either the right side or the left side. You're doing maxillary right, mandibular right, or maxillary left, mandibular left. It's difficult for the patient to control the mandible if both sides are anesthetized, and there's a greater risk of injury to themselves with biting their tongue. So what are the debridement procedures? Before debridement, it's necessary to obtain a written informed consent, which is part of the treatment planning for the patient. It's important for the patient to really understand that the decreased probing depths are primarily due to gingival shrinkage, which may cause gingival recession, and their teeth might look longer, or they might have spaces in between the teeth, or hypersensitivity might occur as that new root surface is exposed in the oral cavity. But we will work with them to decrease that hypersensitivity, and it usually is only lasting for a short time. Now, studies have shown also that the ERG-YAG laser, which selectively removes calculus, may cause less damage to the cementum. Hygienists in Virginia are not allowed to use this, but it is used for something called the LANAP method, which is a non-surgical method of laser debridement. But we're doing subgingival debridement, and that's primarily for calculus removal. And the primary goal is to remove gross deposits from the supragingival as well as the subgingival tooth surface. Specifically, subgingival debridement, the goal is to render a root surface free of biofilm, calculus, as well as endotoxins to enable soft tissue healing. Now, I've said this before, and 100% complete calculus removal is just not possible, even the best of us. Total root surface is not adequate and necessary for tissue healing. We do our best with the circumstances that we have with our patient, and we continue to do our best. Sometimes we're leaving calculus behind because in private practice, that's all the time you have for that quadrant. I have been in situations where I've told the patient, I need you back for another series of appointments before you can consider yourself to be adequately cleaned. There's just, if they haven't been to the dentist in 25 years, you are not expected to be able to do the 25 years worth of scaling. So if periodontal debridement can achieve elimination of inflammation and disease progression, then really no further treatment is necessary. But if you know there's calculus there, you want to get it off. If there isn't isn't tissue response, then they might need more definitive debridement. They might need more advanced diagnostic testing, like the DNA testing or something else, one of those other tests. Chemotherapeutics might be needed, like the Arrestin or something else, or laser therapy, or they might even need periodontal surgery. So some of the root surface characteristics, you have the subgingival microorganisms that release endotoxins, those gram-negative bacteria. They release endotoxins, or the lipoulosaccharides from their cell walls. You do have those endotoxins that are highly toxic compounds that are capable of penetrating the junctional epithelium and entering the connective tissue, which results in the destruction of periodontal tissues. And you've got endotoxins that activate the inflammatory response and the immune response, causing a loss of connective tissue attachment from the root surface, that classic apical migration of the junctional epithelium, and then bone loss. So a periodontal pocket forms and the cementum becomes exposed as well as contaminated. And then you can have necrotic cementum, and that is a very porous cementum where endotoxins and colonization of bacterial biofilm and calculus can readily occur. So endotoxins are found on the diseased root surfaces, but they're weakly attached and superficially bound. We used to think that they were tightly bound. So 99% of the endotoxins can actually be removed by brushing or by using the ultrasonic scaler. Ultrasonic scaling is with the water lavage, is the tip has to be touching the root surface though, but that's all you need to remove those endotoxins. Periodontal therapy, the treatment of the periodontal lesion is the key is to remove the biofilm and calculus, and as you know, that calculus is secondary factor because there's always biofilm on top of the calculus, and it's to reduce the number of oral bacteria below the threshold level capable of initiating inflammation. So we can't sterilize the pocket, but we hope to reduce the amount of the pathogen so the body can heal. So the therapeutic goal of debridement therapy is to control the bacterial infection. Subgingival debridement may cause soft tissue recession. You're reducing inflammation by making the teeth look longer, as we said, and exposing root surfaces to the oral environment. That can cause hypersensitivity. So that can take place immediately or may take 3 to 4 days after debridement for the patient to notice it. And intensity can really increase before it decreases. So we want to have the patient aware of this and to give them products like the Sensodyne toothpaste with the potassium nitrate or the stannous fluoride or the combination of the two to help control that hypersensitivity. Now, what are some of the limitations of periodontal debridement? One of them is the pocket depth. The deeper the pocket, the more difficult it is to do a thorough debridement. Studies are showing after 4 or 5 millimeters, we are doing a lousy job of removing calculus. The best of us are doing a lousy job, but again, we do the best we can. Think about the furcations in the root anatomy. How much time do you have per appointment, as well as what is your clinical skill? Because we all have different clinical skills, no matter who we are. So the most frequently lost teeth in patients receiving comprehensive periodontal treatment are the molars, because it's difficult to remove the biofilm as well as do a thorough job of debridement. So because of that, there's all sorts of modifications to the curettes. They have after fives with longer shanks. They've got mini fives and mini afters with longer shanks and a shorter blade. They even have micro minis now that can get into some of the tightest spaces. Now, do you need all of them in your setups? Absolutely not, but it's nice to have 1 or 2 in your arsenal in the drawer, bagged, ready to go, in case you find something that is difficult to access. But pathogenic microbiota frequently persists in the furcation areas because we can't get them, the patients can't get it, Narrow furcation openings make it even more of a challenge, and our curettes are wider than the narrow furcation entrance. Those root concavities, the trunk of the root, especially found on the proximal root surfaces, trap biofilm and calculus. Think about those mesial concavities on the maxillary first molars and on the first premolars. A lot of what we do with our patient is time sensitive as well as sensitive to your clinical skill. So you might be leaving more calculus behind on one patient because you can't get to it, you don't have access, versus another, versus somebody else in your office might be known for their scaling prowess. They can get anything off of any root surface, yet their people skills are lousy. And it's hard to be good and best at all things all the time, but we do our best. So when the probe is inserted in periodontal tissues that are inflamed, it penetrates past the junctional epithelium and creates a deeper probing depth, because the buoyancy, that tip of the probe can just go right through those cell layers. And this happens because the periodontal tissues are inflamed and the attachment's lost. The disease can be stopped upon treatment, but the connective tissue loss and alveolar bone loss, as well as the periodontal ligament fibers, can't be restored once that apical migration occurs. So the healing process of the periodontal unit consists of an initial periodontal debridement. That's what we do. And when healing occurs, the gingival tissue shrink, and outcomes then can be assessed. Once periodontal debridement occurs and an initial shrinkage happens, you need to wait a little while before you start probing and interrupting those things, because the inflammation might subside within 24 hours. The tissues begin to heal, but you don't want to disrupt that long junctional epithelium from taking place. So let's take a look at the different modalities of healing. When with gingivitis, it's you've got dental biofilm and calculus is removed, and the pocket develops into a new junctional epithelium. Once the junctional epithelium is formed, it attaches to the adjacent tooth as it once did in health, because you don't have any apical migration, but what you have is a long junctional epithelium. Once that long junctional epithelium is formed, the presence of bleeding, inflammation, as well as swelling is eliminated, and the color of the gingiva returns to that nice salmon pink or whatever it was before. Fibrotic tissue doesn't go away. So if you've got a smoker or somebody that's drinking a lot of hot liquids, or is on calcium channel blockers and has gingival overgrowth, that is not going to respond adequately. But reduced probing depths are seen between 4 and 8 weeks, partly, and I have a misspelling there, partly due to the fact that collagen has reformed and a junctional epithelium has once again been established. So we don't want to go heavy-handed and rescale, reprobe an area that we've just treated until that junctional epithelium has had an opportunity to reform. So periodontitis, once the dental biofilm, calculus, and necrotic cementum has been removed, then healing can take place. And that again occurs with the long junctional epithelium, but it's going to be at a lower level. Periodontal disease can be arrested, but the damage that's been done can never be undone. So the alveolar bone and the periodontal ligaments aren't going to be restored to a before disease level. But the same healing that occurs in the gingiva also occurs in the periodontal unit. The pocket is no longer a pocket, okay, but you've got a long junctional epithelium that's present, and it could turn into a sulcus with non-intact periodontium. So the junctional epithelium will be present within 1 to 2 weeks after the initial debridement, and the greatest reduction in probing occurs at 4 to 8 weeks. And that's when we want you to bring your patients back for what we call that perio re-eval. And once the periodontal therapy has been completed, you want to bring a patient back for that re-eval, and that needs to be done to ensure that the periodontium is responding to therapy. Is there still an area that needs to be further investigated? Do they need another round of appointments, or can they, since it's been 4 to 8 weeks, can they take another month or two, depending on when their next recare would be. Can they wait that long? So findings that are recorded during the evaluation are compared to the initial findings. And at the re-evaluation appointment, you're going to be doing checking their oral hygiene status, their soft tissue status, probing depths, clinical attachment levels, bleeding on probing, mobility. You're doing a complete perio assessment as well as a biofilm index and comparing the two. So if biofilm control hasn't been established, then the subgingival bacteria can repopulate in 4 to 8 weeks. When I was a new graduate, they were saying it took about 90 days for things to repopulate. So that's what we were going on, but it really happens rapidly. So if the initial therapy shows improvement, but there's still 5+ millimeters, then the patient should be placed on a periodontal maintenance program and should really be returned to the dental office every 2 to 3 months, because that's about the time that it takes for those pathogens to multiply subgingivally and to start creating damage. We want to stay ahead of the damage. So unresponsive sites, though, should be closely monitored for signs of clinical attachment loss, and then you need to be more of an investigator. If persistent inflammation is taking place, it's usually from incomplete debridement or patient noncompliance or systemic disease, something, but it requires further investigation. So studies have shown, okay, do I ultrasonic, do I not ultrasonic, do I hand scale? And we've come 180 degrees from when I was in school for this, but studies comparing the two are really hard to find due to the wide variety of the designs. But it's been documented that ultrasonic scalers with modified tips, now those are the thinner tips and the left and the right, all right, can produce smoother root surfaces with less damage and provide easier access to the deeper pockets because they are so thin. But most studies have shown that the two are compared, show about the same goals can be achieved. It was found that both hand scaling and ultrasonic both effectively reduce the microbial counts. So it's important to remember that using an ultrasonic scaler or hand instruments, that post-treatment evaluation is needed to ensure that proper tissue healing is taking place. We are now relying on the ultrasonics to do a lot of the work for us. So instead of us going in and spending 20% of our time with ultrasonics and 70% of our time with hand scaling, we're now doing it almost 70% with the ultrasonics, maybe 20% with the hand scalers, and then the other 10% is with biofilm removal and that type of thing. We're using lasers in dentistry now, and lasers can be used with hygienists in Virginia for deplaquing or periodontal decontamination. They are approved by the Food and Drug Administration as a medical device, right? And each laser has a different wavelength, so it's using a light with the wavelength that's used for different procedures. So there's more than 20 cleared indications for using lasers in perio, including sulcular debridement and pocket debridement. We're using it to reduce bacterial loads, but you can do some cutting with it, or dentists can do some cutting, such as scaling and root planing and reshaping the bone and other surgicals. But the results of using lasers is still in its infancy, so long-term studies haven't been out there yet, but theoretically, it sounds like a good thing. So you've got your CO2 laser, which is best for soft tissue incision, that's cutting, frenectomies, reshaping the gingiva. This laser is kept away from the tooth surface. The dentist is the only one that can use that. Their lasers are being used to reduce subgingival bacterial loads. All right, the YAG laser has been shown to be very effective. We are not allowed to use that. Because the use of lasers is considered to be closed, the clinician can't see it subgingivally, there's still a lot of concern about what can be done to the root surface. But healing response that's expected with the use of, say, an YAG laser is new attachment through regeneration, and that's something we don't see with just plain hand instrumentation. And healing after removal of subgingival calculus is just the long junctional epithelium. So wouldn't that be fabulous if you could get regeneration of the connective tissue? So we're using the diode laser, and we're using it to decontaminate the pockets. There's also something called guided biofilm therapy, GBT, and that is similar to a prophy jet or a, if you know what that is, but it's using either glycine powder or erythritol powder, which is less abrasive than the baking soda powder. It's very fine. It's used at a different power because what you can do with the glycine, the guided biofilm therapy, is actually not only remove supragingival plaque or biofilm with it in stain, but you can put on other tips to decontaminate root surfaces subgingivally. So we're going to be learning more about this guided biofilm therapy. Germana, you have that in your handies. MEC, we have handies. They're just not out of the boxes yet. But it's a new approach. It's great for orthodontics. It's safe to be used on implants. It's great if you've got the perio tip to actually angle it subgingivally to remove the biofilm subgingivally. And what this guided biofilm therapy is saying is if you do that prior to, you disclose the patient, do your OHE, and then you use this machine, it makes the hand, all of your hand scaling and ultrasonics and everything go much faster. So the therapy, the end all, is that it's based on the data for what is evidence-based, as well as the microbial studies and clinical studies. So the decision to perform periodontal debridement as a definitive treatment should really depend on how severe the periodontal disease is, as well as what the inflammatory state is for the patient. There are patients where you know they're still going to need surgery after you do the initial preparation. You just know it because miracles happen, but not all that often inside the mouth. So a selection of proper instruments involved considering, you need to consider the amount of calculus, the tissue tone, how friable is it, what are the probing depths, the root morphology, and the location of the calculus. The primary goal of debridement is to make the root and the soft tissue biologically compatible to allow for healing. So in most cases, periodontal debridement improves the tissue by decreasing both the gingival inflammation, so that's the shrinkage, and the probing depths. And if the self-care or home care isn't continued, then the pathogenic bacteria return to the site within 4 to 8 weeks of non-compliance. And the patient requires, therefore, continuous maintenance and biofilm control and motivation. But healing is considered complete after about 3 to 6 months after the final instrumentation. So that's usually a one reevaluation appointment and one perio maintenance appointment later. Clinically, there should be fewer bleeding sites, more soft tissue recession because of the shrinkage, as well as a regain of that clinical attachment level. So let's go over a couple questions. Which clinical presentations may be expected in a patient after periodontal debridement? And it's that long junctional epithelium that we've talked about. Once healing from periodontal debridement has occurred, what can be expected? Okay, the clinical attachment level hopefully is improved. We're not going to get the bone restored. The periodontal ligament fibers aren't going to be returned. Deep pocketing is present is not one of the outcomes that we want. So that was the only one. Oh, and where's my question? Okay. Bone and periodontal ligaments cannot be restored. Okay, that's true. I gave you the answer there. Successful periodontal treatment and regeneration of periodontal tissue depends on the removal of sub and supra calculus. healing is considered complete after how many months? 3 to 6. So you've got a patient coming in like this. Where do you even start? What is that clinical attachment level? What instruments do you think you're going to be needing? Is this a perio maintenance? He says he's been in 2 months ago. Okay, that's what the chart says. But are you going to need to root plane all of these? So again, what one person presents with is going to be very different from what another person presents with. And that, my friends, is the end of this chapter.